All right, everyone. Thank you so much. We will start back up with our third theme for the day, looking at some issues surrounding reimbursement and a lot of the policy changes, both when it comes to Medicare and Medicaid, as well as private payer policies as well. For our first session, we're going to be looking at evolving policies on Medicare, Medicaid, and ACA funding, all very timely topics right now. And I am joined by Nora Cox, who is the Chief Executive Officer of the Texas eHealth Alliance.
Good. Thank you, Lydia. Now you guys actually get to hear me on a panel where I'm actually invited to speak instead of just speaking during all the other panels. I'm actually have rethought kind of my initial thoughts on this based on something that was said this morning that I thought was really interesting because I had thought about it, which is this disconnect between things like the OB3 Rural Health Transformation Program scoring that specifically mentions telemedicine and telehealth, and the fact that we don't have a fix on the Medicare side. I think there is enormous sort of dynamic tension between the federal government, the state government, and the private markets right now. And I think we're seeing that sort of play out across the different pieces of the telehealth delivery system. So you're saying to the states, we're going to score you. We're going to score you on licensure reciprocity. We're going to score you on remote patient monitoring. We're going to score you on all these things. And then we're going to take telemedicine away from large swaths of your population. And in defense of the administration, obviously they don't control Congress. And I'm putting that in air quotes just a little bit. But I do think that it underscores how difficult it is for anybody to do planning. Like listening to Michelle talk earlier about there's uncertainty, and if you're trying to sell a company, or you're trying to build a company or grow a company, having that regulatory uncertainty wrapping around you is really difficult. And in defense of the Rural Health Transformation Program, I will say the rural component of Medicare telehealth will be protected. Going forward, it's the expansion that we're all sort of looking to really get our hands on. So they might not have thought that was that big of a deal. But my observation would be when you send these mixed signals to any market, which is essentially what Washington, D.C. is doing right now, causes a lot of confusion. People don't know which way is up. They don't know how to plan, kind of all of these things. So I think just, Lydia, for kind of an initial layout, besides the fact that you wake up every day and there's the potential that things have changed, right? Everybody's sort of on hold waiting to see if we're going to get a deal on subsidies. I don't think we're going to get a deal on subsidies. I think there's going to be show votes, but I would be very surprised if there was an actual deal that had any substance or any meaning to it at this point, because they've just made me super cynical and I just don't think the votes are there. I think it's creating a lot of strain on providers, and that strain gets passed on to their vendors, because you might want to pitch a new service offering, but if they're not sure what their revenue looks like, they're less likely to sign the contract. And so it kind of has this drift effect, right, all across the ecosystem. And I have other things to say about some of these more specific pieces, Lydia, but I thought I would start there and kick it back over to you and see what you've got to add.
Sure. Yeah, I think there's been a lot of discussion. It's popped up a few times over the past year of there being some kind of health package beyond just subsidies. Another big issue was PBM reforms, which was, at least in the past, been tied alongside to the telehealth extensions as a pay for. There's been a new bill introduced that just has the PBM reforms standalone without any telehealth. And some of the others, I think these discussions started in December of last year, which was before we had the whole situation where Elon Musk tweeted and then tanked the entire deal that was about to pass. And this health package was part of that. It came up again over the summer after the OBBBA, but there wasn't much interest in doing anything after that either. And again, right now with some of these discussions around, well, if we're doing subsidies, what if we do a larger health package again? But I think I would agree in that There's a pretty low likelihood of anything actually passing. In addition to the votes that were already had that did already fail this afternoon, there was also a discharge petition that was filed to try to get a different deal on the floor, but that's not likely to go anywhere as well. So I think I would agree with you there on that, at least on this current iteration of any sort of health package. We're finding the same thing as we discussed earlier this morning, that there's really no will to get anything actually done.
Well, and I think what adds a level of complication to all this, and some of you have heard me kind of go over this either on the webinar that we did earlier this year or some of the previous CTeL events, you really have a very scary double whammy heading in the direction of the states that did Medicaid expansion. So first of all, keep in mind, Medicaid expansion is not exclusively a blue state issue anymore. More states that are considered purple and even red, like Oklahoma, went ahead and did expansion. And I think North Carolina was the only one that did a trigger saying if there was changes to kind of the deal with the federal government, they could roll expansion back. So a couple of things about that are important to keep in mind. First of all, my cynical side, which is Texas is not a Medicaid expansion state. Texas has always argued against doing Medicaid expansion, that the federal government would change the rules and then they'd be left holding the bag to pay for it. Texas was always told that would never happen. And that's exactly what happened in OB3. That's exactly what happened. So I've got a bunch of very smug, self-satisfied legislators saying, see, federal government can't be trusted. They're like Lucy with the football with Charlie Brown, and they're just going to yank it away. So the red states that didn't expand are probably going to double down from a political posturing perspective. The thing that worries me more is at the same time that we are reducing hospital supplemental funding, which is a bunch of the big cuts in OB3 to Medicaid are not to the baseline program, they're either to expansion with things like work requirements, or they are changes to supplemental funding. The majority of coverage gains from the Affordable Care Act are in Medicaid expansion. They're actually not in the exchanges. So no matter what happens with premium subsidies, which I do think are likely to expire at the end of this year, that's going to put downward pressure on Medicaid, because some of those folks are going to fall into Medicaid, and some of those folks are going to fall into a donut hole of what was Medicaid before the OB3 cuts. So you have this doubling down of economic pressure on the expansion states that we're getting billions and billions of dollars to shore up their healthcare infrastructure between Medicaid expansion, supplemental funding, and the exchanges. And now without the subsidies, people will fall off the exchanges. Even if they don't fall into Medicaid, they're going to fall into EMTALA, and they're still going to be in the emergency rooms. They are not likely to be seeking care. And so that's going to be a doubling and kind of tripling. My state is feeling a little like we dodged a couple of things that could have been a problem for us, but that also means that we still have people coming to the emergency room as their primary source of care because they don't have coverage. So it's a real double-edged sword for policymakers to try to figure out a way out of this. And with all due respect to the speaker, as we said earlier, putting HSAs and innovation on a list and giving it to the media is not a health plan. It's not a strategy. It's not going to be enough. And the speaker, Lydia, you and I have talked about this a lot. The speaker has tight margins. Senate Majority Leader has tight margins. The American people keep doing this mixed messaging where there's a virtual tie between the parties, and that makes it really, really difficult to move policy. And outside of the healthcare industry, I don't know that anybody's really thinking about that economic trickle down of what's going to happen when all these things kick in at the same time. The subsidies go away, supplemental funding gets slashed, people aren't on the exchanges anymore. Medicaid expansion, when you start doing 6-month eligibility checks instead of annual eligibility checks, we all know that there are eligible people who will not be on Medicaid that should be on Medicaid because they can't get through the administrative hoops. And I say that as someone who ran Texas's Medicaid program for years. So I know the games that states play in creating barriers to people accessing care. So that dynamic, it worries me that it's not getting talked about at the level it needs to be talked about. And instead we're going to be doing like a rescue mission, like a Marshall Plan for the safety net. because we're going to let all these things collapse in on themselves. And one last thing, I know there's some charts saying the economy is getting better. Yay! Most Americans still don't have $1,000 in their bank account in savings. And so we put people, to the extent that they are in the exchanges, on high deductible plans, and they don't have first dollar coverage for lots of things. They're still not going to the doctor, and they're still turning up at the emergency room sicker than they need to be. So EMTALA is not a healthcare plan. It's not a healthcare strategy. And I worry that we default to that because we can't solve all these other problems.
You bring up a great point, Nora. We have, emergency rooms have been the ongoing default to cover a lot of these patients that fall below the socioeconomic line, like Medicaid patients, because they have really difficult times getting primary care providers. But another thing that we've talked about and that we're going to continue talking about at CTeL in the future and as part of our 2026 plan is how to get patients access to data, because they could stay out of the data on their cell phone plans. They could stay out of the emergency rooms if they're able to contact primary care providers. But if internet is only available to them on their data cell phone plan, then they have a likelihood of going into the emergency room.
The one thing I'll add, though, especially in our area, they come to the ER because they can be seen, taken care of, and not expect to pay right at that moment. Primary care expects that payment as you walk through the door. Yeah, so our ERs are flooded. I mean, I know individual names of patients because they jump from ER to ER when they have it. So with that being taken away, I don't know, even if we give them cell phone coverage, if they don't have some way to pay for that primary care or urgent care visit, it's still going to come back to the hospitals and the ER. And that's one of the reasons I think we'll see hospitals start collapsing and combining and everything.
But even Medicaid.
If it's Medicaid and they have Medicaid, then it will pay, but they'll still expect, and I don't know enough about what they're doing with the high deductible, they'll expect that payment up front. At least the ones that aren't subsidized by our hospital will expect that payment up front.
Yeah, so the Medicaid clients, you can't charge them. So you're not going to be charging them for the most part. But we have a whole other layer. And there's a great report, Krista and Lydia, that I can send to y'all if you might want to share it with everybody here. We had a think tank in Texas do a deep dive on the uninsured, because they were trying to figure out whether Medicaid expansion was really going to be helpful in my state or not. And the conclusion was there's 5 different groups of the uninsured, and they all have different priorities. And only 17% of them would benefit from Medicaid expansion. Then you've got the working poor that don't have kind of $1 for coverage. Then you've got people who habitually only use the emergency room and sort of walk away from the billing. Then you've got the people that are worried about immigration. And I don't have to tell anybody in this room how much more worrisome that is, that we have people who are avoiding these systems until they are too sick, basically, to function. And then you have people who swim in and out of private coverage to Medicaid, and they sort of go back and forth. And the incentives for all of those groups are different. So even if my state, according to this paper, did expansion, we would still have these other groups that we wouldn't be able to pick up under Medicaid. So it's really complicated underneath the surface. And I do think I'm using the word culture, and I don't mean that in sort of an ethnic sense. There's a culture around the use of the emergency room that differs from community to community, but there is enough of it that is the reason that these cuts to hospital supplemental payments are so critical to the states that have been receiving those dollars. I mean, Texas receives billions of dollars that are distributed to our hospitals to try to make up for some of the losses that they take because they're treating a population for whom there is no card, be it a personal card or an employer card or a government card to put on the table. And that's when you add that to the fact that medical inflation is increasing at like 6% a year, so faster than standard inflation. And I don't think it's all Ozempic and Wegovy, and I'm sort of tired of people telling me that that's the reason. I think it's way more complicated than just the GLP-1 medications, although they are expensive. And I'm not saying that they're not. I just think there's more dynamics going on with cost. And that's where telehealth, again, has a great role, because when deployed properly, it's very cost effective and it can get to people faster. And I shouldn't have to say that. And yet I feel we still have to say that all the time to try to make that argument.
Yeah, and maybe we can think through also how these cuts are impacting the actual virtual care programs that a lot of organizations have. Because not only is there the upfront cost of building the infrastructure to support a telehealth program, to support a remote monitoring, especially if you're buying equipment out front, also the cost of maintaining those. And we're seeing that a lot of year after year, many hospitals are growing their health IT spending by the fastest. It's one of the fastest growing areas of spending for hospitals year after year. And so as these sources of revenue get cut, how are we responding with in terms of the resources needed to build and maintain these programs when the overall resources available to a hospital health system practice are becoming smaller?
Well, I mean, maybe everybody can make enough money by redoing their coding to have some cash laying around to be able to buy more equipment. I will say, I think the price point has gone down for some things, but not for everything. I think you still also have broadband gaps. We certainly have broadband gaps in Texas, primarily on the patient side, to the point about data, not so much about on the hospital side. I've got one hospital in Texas that still doesn't have an EHR. So they're on paper and they're feeling pretty good about when the power gets cut in the next winter storm that Texas can't handle, they'll at least still be able to use their paper charts. So we still have infrastructure gaps that we haven't filled. And some of that is definitely on the patient side. That being said, the head of my rural hospital association does give this pushback frequently, and he's not wrong. Every rural hospital is doing teleradiology, so they've got a pretty big pipe. So maybe part of the thinking as we work through the rural health transformation funding is making the rural hospital that has the big pipe a hub for other things, because maybe people can get to it if we can't get broadband out to their homes. Or this is what the techie nerds in Austin keep saying to me, Nora, it doesn't matter. In 2 years, everyone will have Starlink. Okay, I mean, maybe, but I'm not willing to bet on that quite yet. And then what do you do when it goes down and you've built services into your hospital that are dependent on that connectivity? So I just don't think it's that as easy as some of the nerd herd makes it out to be.
It still has to be paid for. And at the end of the day, especially in our region, most of the counties, the average annual income is $37,000 a year. They're not going to be able to pay for it. The other thing I would say too, especially in the rural areas, and I think I know the hospital you're talking about that's still on paper because I've talked to one of the leaders there. One of the things that we run into, even though we've got, Bristol, Tennessee, Virginia, it spans both states, that's considered a bigger city. We still have one single way in for broadband and one single way out. And during Hurricane Helene, it got cut along with cellular. So we were completely ostracized for about a week until they could get everything up and running. And I'm sure other rural areas are like that too. So we had 20 hospitals. One was completely destroyed. Another one, all 4 bridges to the hospital you could not get to that hospital. We had to take the air medical to fly just general supplies to it. And then 2 other hospitals were very much bottlenecked because bridges got washed out. So when you think about broadband and all of that, we still don't have the luxuries that the bigger areas have. So when you put everything on EHR, whether that's AI, telemedicine, or whatever, you're still at a limit to where you're going to lose everything.
Aside from the infrastructure issues, what about, can we tackle the incentive programs that to me are kind of counter to the adoption of telehealth? In the value-based program, I'm hearing more and more from organizations that they don't want to bill for remote monitoring, for example, for some of these patients, because that's going to increase the cost of care. And that's going to create a problem for them under their value-based care and risk models that they have with these payers. Since we have support at the executive level for value-based care payment models and things like that, can we start to maybe think about how do we angle into, let's not de-incentivize, and make that a penalty?
Yeah, I think especially on the issue of value-based care, we actually have a webinar scheduled for next week with an attorney from Holland and Knight to go over the new access and tempo models that were announced by CMS and the FDA that were value-based payment models focused on utilizing digital health tools for chronic care. And so I think especially seeing that and how our organizations can get involved in that and how that may or may not change the landscape of value-based care. So next week on Thursday, I think that'll be a good webinar as well. Just wanted to shout that out.
No, I'm glad you mentioned that. So Elizabeth heard me talking at the ABA Health Law Conference earlier this week. And one of the things that I talked about was the American Medical Association needs to get on it. We need codes. And we need codes that are not just for incident. We need codes that are not just for activity. We don't have enough codes. We don't have the right codes. And our colleague, Lindsay Brill, who's from their government affairs team, was in the room, and I called her out. I was like, Lindsay, codes, please get me codes, because we don't have a billing architecture and nomenclature that works for us. It works against us. And I'll give you an example of how that plays out, say at a state Medicaid program. So states have to balance their budgets. Federal government does not. Y'all have heard me grumping about this for years and years, but it's true and it continues to be true. So pre-pandemic, we would do this utilization review of telemedicine billing in Texas Medicaid. And everybody would go, oh my goodness, utilization's grown 2,000%. Yes, from 50 to 150 encounters. Calm down. Calm down. So they were only interested in the check marks, right? In the check marks. And a lot of the scoring methodologies for Medicaid across the states are really utilization dependent. So we don't have enough of the methodologies that we need to do the capture for the stuff that you're talking about. So I think the models that are going to be talked about next week are good starting points, but I also think I am doing a public pressure campaign on my colleagues at the MA who they're like, they have a digital health committee, it's meeting, it's really exciting. No, now I don't have time for this, because as long as we're so heavily dependent on CPT, the way that CPT is structured, then I think it's going to be really difficult to pay people what they should be paid for the sorts of things that you're describing. It's not impossible. You can do it. You can do PMPM. You can do what I like to call fancy fee for service. Like there are things that you can do, but because of AI, I have these crazy dreams of a future where we would have codes that are really value codes. And there's only a handful right now that even come close to fitting in that category. But AI may be the tool that lets us do the analysis that can help us figure out what those codes actually ought to be. The payers aren't going to like it because they'll have to change their IT systems. Oh my gosh, so scary. Don't care. If we don't flip this like you're describing, then we're just going to kind of spiral down, because we are heading towards, it's my strongly held religious belief here, Joe. Baby boomers, I love you. You scare me to death. They are heading straight for their high utilization years like a rocket ship on top of the system that was designed to give healthcare when they were born. And that is hugely problematic. So those of us that are in the transformation business have to stay in the fight, because I'm very worried that they're going to get to their high utilization years and the thing is just going to collapse in on itself. And that's a very scary thought, because you can't build good policy on assumptions from the 1960s and the 1970s. You just can't. And while I'm ranting, remember when Medicare was passed, people died at 67. So you were only supposed to be on Medicare for like 2 years. So there is some fundamental programmatic redesign that needs to happen, Medicare and Medicaid, not just to support virtual care, although that's incredibly important, But to align the incentives in those programs and the amount of political courage it will take to do that, we don't currently have. But it doesn't mean that as an industry, we can't be having the conversations that build the case that move us in that direction, because that is something that I think I've said repeatedly in this forum and in other forums. We have to do it. No one's going to do it for us. I agree. No, you're 100%. You're 100% correct.
Cycle's too long for
Yes.
that. It's not a now, it's a 2027.
Yes, it is too long, but as long as the federal government relies on them for the code sets, that's the tool that we have. But you are correct. It does take too long.
And that may be changing as well. There's been some more tension. I think Bill Cassidy, Senate Help Chair, has started going off against AMA and CPT and RUC, as well as what we saw with the fee schedule rule with the implementation of the new efficiency adjustments, where all but only a handful of codes will now get I think somewhere around like a 3% decrease in valuation every 3 years or so. And CMS directly cited that it does not trust the AMA's evaluation of efficiency gains. And so, at least in the past year, there has been some, both from Congress and from the administration, of very significant expressions of skepticism towards the AMA and CPT editorial panel and the RUC. And so whether or not that continues may affect these processes that we're talking about now.
Was there any suggestion of what the alternative would be?
No, there's not been a suggestion of what the alternative would be. I mean, I won't speak for any of the people Lydia just described, and she may have insight that I don't have. I don't know that you can take their copyright away, especially when you don't have a system designed to replace it. I think that's a well, no, and we have to think about it and we have to talk about it. But what they may be doing, because this would be typical for this administration, goosing them a little bit, right? Kind of trying to put some fear and maybe some momentum into the AI. Look, I have friends that work at the AMA. I'm friends with a bunch of those people, but I'm pretty sure that's a RICO violation. I like to call them the cartel, because they have an absolute capacity with an announcement that no one can stop from happening, from upending entire sections of the healthcare system, which is part of what's led to the skepticism that Lydia was just describing. I think it's a problem, but we don't have a replacement lined up. We don't, not to mention the one time, it's going to feel, if it happens, like Y2K. So I did Y2K remediation for Texas's Medicaid claims system, which is why it will say nerd on my tombstone when I die. And moving away from CPT to anything else will feel like Y2K, because it will be every system in the healthcare system that processes a claim, that's tied to an EHR, that's in all these places. It would be a massive change, but I worry if we don't do it, it's another part of that spiral in and down that we're trapped in, that we're having a hard time getting out of, which is why we have all these struggles with payment policy.
And I think one issue related to coding, but also on the issue of telehealth, are new telehealth codes, the 9800 to 98016, that have been pretty spottily implemented across different payers. Medicare says no. Some Medicaid payers are using it. Some private payers are using it. We're actually working with some research partners from University of Mississippi Medical Center to do more of a thorough evaluation on how the implementation of these codes has changed the actual reimbursement for telehealth services, compared between payers that use the traditional E&M codes and payers that are now requiring the new telemedicine specific E&M codes. So I think, kind of relating to this issue of codes, there are also what we're seeing is across the inconsistent implementation of these new codes, potential for reimbursement differentials as well.
Well, and I'll take that a step further. So I'm sure many folks in this room have been part of the conversation about payment parity. for telehealth and telemedicine, right? We want an acknowledgement that we're doing the same service. It should be paid at the same level. A bill along those lines gets filed in Texas every 2 years. I have to go to whoever filed it and say, so you don't ever want us to do value-based purchasing in telehealth? And they say, well, what do you mean? I'm like, well, you're telling my people that they have to pay exactly the same as the fee-for-service fee for this service. So no value-based purchasing for telehealth. So we had to negotiate with my medical association very carefully some language to exclude value-based purchasing arrangements from the parity requirement, because we wanted to make sure that if someone wants to enter into a PMPM for telehealth, that they're not statutorily prohibited from doing so. So I think that's sort of an artifact of the fact that we started with modifiers, right? And then people would tell me, oh, we don't bill with the modifier, we just bill. Oh, well, that's not good. Okay. Or, oh, well, yeah, the insurers, they know they have to pay on the CPT code plus the modifier, but now they're declining everything that's place of service too. Remember that wave? A lot of us had to ride that wave out. So I do think, to Lydia's point, it's going to be interesting when we have some data over whether having telehealth specific codes has actually helped us or not, because I think there's some nuance under the covers there that is going to be teased out by the data kind of in the long run. But in the meantime, we're still tied to these codes, and that's what we have to use and to bill for the most part. And that's what we're going to be doing our analysis on. So it just feels to me like it should be telehealth specific codes, and that should be better, but I'm not convinced. I want to see the data. I'm a little bit skeptical, just because I think the application of the codes is going to be uneven, and we've got to let that sort of play itself out.
Coming at me from all directions. Nora, if I understood, you said you would consider maybe 2 or 3 codes to be value codes. Did I hear that right? And if so, what I'm wondering is, what would be an example or two of a code that you think fits that category or comes close?
So I looked them up earlier, and now I'm drawing a blank because of the medication that I'm on that sometimes causes my memory to get blanks. So I will look that up here in a second. I do apologize. I prepared for that. I prepared to make that comment, and I looked it up, and I have a blank spot in my head. So I will figure that out, and I'll make sure that I mention it before this is over.
In my case, it's not necessary to refer to medications for this very problem.
Yeah, that's the way that I try to have a sense of humor about we're being recorded. Ooh, it's AI. Ooh. So I was joking with Micah earlier that there are some people in Texas now arguing that the AI note takers are people, and they need to be allowed to sit in open meetings in Texas state government. Yeah. No, they're not people. You are correct. No matter how nerdy I am, I still don't think that they are people. Lydia, what else is on our list?
Speaking of codes, we could talk fee schedule. Sure. So we put out our summary of the fee schedule final rule that came out last month. I think the big change, at least from telehealth, is the revisions to the telehealth services list and the process for adding codes and services to that list. Specifically, that CMS is now removing the requirement that there be demonstrated clinical efficacy of a given service delivered via telehealth to be added to the list. And so now there are only 3 requirements for Medicare to consider adding a service to the telehealth services list. One, that it is a service, that it is capable of being performed via telehealth, and that it is capable of being reimbursed by Medicare. And so with kind of lowering the barrier of entry for new codes on this list, it's very possible that we may see an expansion of codes and services added on it. I think it's also important to note on the efficiency adjustment piece, CMS specifically excluded codes that are on the telehealth services list from receiving these efficiency adjustments every 3 years. And so any service that gets added to that list is now being considered for exclusion from those 3% reductions every 3 years.
I think the other thing that I thought was interesting in the Medicare fee-for-service updates was the group codes that they added. I think it's an obesity management code and a group therapy code for telehealth. Texas was deeply skeptical of anything involving groups of people as clients being a telehealth service after the pandemic was over. So we moved away from that. So I just think it's very interesting that Medicare actually moved in that direction. It shows that those group sort of therapeutic settings have some value to Medicare. So maybe the states that don't have them for Medicaid have some precedent now to try to get them back. I was trying to find the answer that I had looked up earlier to Joe's question. So the one I had in mind was some of the category 2 codes, 3074F, 3075F for performance measures, like keeping blood pressure under control. So that's not an incident, that's an outcome. And that was in the most recent CPT update. Where's Carol when I need her? Because I'm trained in CPT coding, but it's been a long time since I've actually coded a claim. But that's the sort of thing that we need building blocks for, because if you're using remote patient monitoring, if I'm Medicaid, I'm going to put my payer hat on, right? Used to be at Texas Medicaid, used to have to do these policies for the telemedicine, telehealth for Texas. It'd be one thing to be like, okay, I've had 1,000 people on remote patient monitoring. And so I've spent $1 million this year paying those doctors and those home care agencies for the RPM incidents, but I don't have any way to really, without getting into the charts or forcing them to report stuff back to us, I don't have a good way to be tracking the outcomes. So we do, I think, need codes that do that to be paired maybe with the incident codes. So you've got the activity and then you've got the outcome. Short of getting a new code set, that may be the shortcut that gets us there, at least for some of these services.
The assumption is that primary
Hey,
care doctors.
Nora. Hey. Hi. Oh, I've been
Hi, I was taking your
lurking.
in vain.
Lurking.
Did I have that
heard
right?
my name mentioned and my ears pricked up like dogs when I say beach. But you know, the HEDIS measures and MIPS codes would be a great way to track outcomes for a different use case, perhaps, because there are a lot of codes in existence, but I don't know how you'd quantify it other than doing the longitudinal study of, checking to see if the diagnoses changed or additional ones were being managed. And then also if the patients either in person or, or video visit or e-visits decreased. So there might be a better way to parse it out, but
This is Nora, Carol. Actually, I think here's the thing. I have been listening today and I understand the grumping about the electronic health records. I do. I work with those companies. I understand the grumping. But if we're going to get to any kind of longitudinal look in order to be able to do what you just said and do it worth a darn, we have to capture that stuff somewhere. And it shouldn't be a bunch of secondary and additional processes on top of the stuff that we already do. So the technology continues to be really clumsy, and I get that. But I'm hearing, as I talk to people in my other professional vertical, which is CMS, ONC, ASTP, they're like, we gave you people millions of dollars, you people being all of us, to get electronic health records, and now we want something back.
but they didn't
CMS.
ensure that it had to be interoperable.
Right. What? You want
They
it to
should
be
have rolled
what?
out one EMR.
Yeah.
There's no
that-
interoperability, so there's no tracking patient outcomes across health systems unless they give us access to their central working file.
Well, It's going to be interesting. So this is a side note, but it's really not. And I was on the fence about whether I was going to talk about this, but now I'm going to do it because
Good.
the door is now open.
You're
How many
welcome.
people in this room know who Amy Gleason is? Okay, so Amy Gleason is Doge, CMS, ONC, ASTP. She's one of the people that put together the Rural Health Transformation Program application. I've been told by a reliable source that she's scoring the state's applications. And a couple of weeks ago, I was in Nashville at the Sequoia Project annual meeting, and she spoke. And we were not allowed to keep the slides. So the slides were confidential. People got in trouble for like taking pictures. That being said, Amy Gleason has an adult child with serious medical needs who has 46 patient portals. And they have put all of her daughter's records with her daughter's permission into ChatGPT. And this woman who is driving federal policy for interoperability got up in front of Epic and Oracle Cerner and, you know, the Messiah himself and straight up said, y'all suck. And that's why I'm going to push all of these additional deregulatory patient portal initiatives that don't need congressional approval. So she's using the regulatory authority. She was US Digital Service pre-Doge. So she's been around a time or two. So if you've not looked at the Levitt Partners Kill the Clipboard white paper, has anybody else in this room read that besides me and Lydia? Nerds, get on it. Come on. This is incredibly important federal policy direction. The person that wrote Kill the Clipboard for Levitt Partners was the other finalist for the Office of the National Coordinator position that went to Tom Keene. And the states that are putting Kill the Clipboard principles, which is essentially literally pre-boarding, right? Your patient pre-boarding, trying to get that digitized in any place that you can. But it also speaks to the point that Carol was making, which is Amy doesn't want her daughter to have 46 patient portals as a medically complex person. She wants to see real interoperability. Yeah, there we go. Thank you. I highly, highly recommend that everybody in this room read this. We integrated some of this into Texas's RHTP application, which is online and you can read it if you want. This is a significant, this is now, even though this is a private organization's paper, it was written by somebody who has significant influence over the direction that ONCA, STP, and CMS are taking. So I really recommend that you read it if you're working in these spaces, because I don't think we can separate telemedicine service delivery conceptually from interoperability anymore. I think these things are going to come together more and more, and we're a little off topic, but I think, again, it all relates. The other big announcement at Sequoia Project was, of course, that they're about to start, at least in theory, enforcing information blocking, which may mean, I mean, I'll believe it when I see it, but the truth of the matter is if you're a telehealth provider and you get a request for records and you don't respond, you could be in jeopardy with the federal government. So they see that as a stick as opposed to a carrot to try to get people to share data.
But everyone knows that is really a direction at Epic. That's a shot off their bow.
Well, of course, but they're 42% of the market. You shoot at the biggest target you can get at if you're.
And the biggest
defense.
blocker of information.
Like I said, I mean, it goes back to Farzad Mostashari's white paper on no walled gardens. Like, this is not a new fight with them. It's a long-standing conversation. I will say, though, that they're reporting, OCR is reporting that most of the complaints have been against providers and not against certified EHRs. We'll see, because there's been like over 1,000 complaints that the feds have received. And they've said publicly that most of them have been against providers. Whether that, once they dig into it, turns out to be their EHR, you know, depending on how much of that gets made public, I guess we'll see. But it is, these things, you can't really separate them, right? Because none of the payers feel like they've got the longitudinal information they need. Providers are still having to do a bunch of stuff manually. We haven't really done a great job with any of these pieces. So as these federal programs contract, as the subsidies and exchanges contract, and as Medicaid contracts, particularly in the expansion states, I think that's really going to create some negative pressures for providers And maybe that will force Congress to act. I don't know.
But going back to what she said, it may not actually be the provider that is the problem, but we're holding the provider accountable, and then that it's going to go back on that health system to have to go back to literally print out records or whatever and go an old school way rather than to get these EHRs to be interoperable.
Which I think you're correct. I think it's a pressure. I think it's a pressure campaign.
I just see us trying to solve it and taking care of the problem to get the feds off our back rather than go back to Epic. Because that would be quicker for us to get it turned around. Just looking from a rural healthcare perspective.
And that's why there's a lot of conversations about health information exchange and what is that and what should that look like. I'll tell you, the rural hospitals in Texas, we're looking at all buying a single instance of Epic. Because then that would just solve that problem, because some of them use their high-tech money on products that are not good. For example, I know of one EHR that can't segment sensitive test results. So you know how under information blocking, you've got to release those patient test results right away? Texas passed a law saying you can hold malignant tumors for 3 days. So you can notify the patient. Well, I've got at least one EHR in my market that can't do that, which means the pathology reports of the malignancies are going straight to the patients, and it's causing angst. So I've been making phone calls about that because I think that's also, I think that's a problem. And we want patients to trust that we're using technology responsibly, which is sort of my bigger picture rant here. And that it's not a good look when people are finding out they have cancer from an email.
Is this an 80-20 though rule thing? I mean, I get it. That's not right for those patients. But if Dallas Children's and Texas Health Resources and Christus and whoever else in Texas is all on Epic, and they're seeing, millions of people throughout the year, and that one facility, we're trying to boil the ocean, right? To find the one spot that's not boiling.
I'll say this, policymakers are anecdote responsive and not data responsive. That's one of the themes that runs through this whole thing, right? Like I joke, I say this all the time, the plural of anecdote is not data. It's not. People think it is, but it's not. Two anecdotes don't make a data. That's not how those words come together. But whenever you're talking particularly about cancer and particularly about malignancies, people finding out that they've got a malignant tumor from an email is causing people to have panic attacks, and it's causing them to go to emergency rooms, and the medical societies, I'll say, are very upset about this across the country. So I think you're going to see that trend line continue because cancer is so emotional for people. I just don't think I don't think the 80-20 is going to be satisfying to legislators whose constituent found out they had cancer from an email, no matter who they get it from. I hear what you're saying, but if I could work on the 80 instead of the 20, I'd have a very different job. I feel like I don't know about you, I spend a lot of my time on the 20% instead of the 80%. Stuff that's sticking its head up out of the hole, right? Like a prairie dog, or maybe it's whack-a-mole, right? It's whack-a-mole. We're always whacking at the moles. So again, off topic, but not off topic, because part of the reason we have these issues with the spend is the inefficiencies in the system. And if we had a system that was interoperable, that did appropriately share data, that allowed us to do longitudinal tracking, that allowed us to really, maybe put Carol in charge of building a new system to use HEDIS and MIPS in an appropriate way. Like, there are things that could be done, but the forces working against it are inertia and a lack of political courage. Not that I have an opinion about that. I'm just saying, I think the amount of political courage it's going to take to solve some of these things is in scarce supply, and in DC, at least right now.
What do you see as a path forward?
Well, I mean, I think the most likely path forward or the ideal path forward, because those are two different things. I think what's likely to happen is they're going to kick the can down the road until the primaries. Now, the primaries are going to be very, very interesting because that will be sort of a test of the president's support and of the support for this administration. So Joe and I were talking earlier about the current Health and Human Services Secretary. I would be shocked if he makes it to the end of 4 years. Just professionally startled. But do you cut him loose after the midterms, after the primaries? Like, where does that happen? I think there'll be a lot of downward pressure for a change at HHS if the pushback continues on some of these things that we're seeing. So I think step one is the primaries and kind of what is the strength of the MAGA coalition at that point, because we'll know in some of these bellwether states kind of where that sits. Now, that's a primary, so those are motivated voters, but we all know what motivated voters do to the people that they vote for. That becomes their constituency. So that's, I think, the first piece. I think if that does not go well for the president and his party, then I think you might be able to carve a lane on subsidies. I mean, I'm just going to be really honest with you guys. We're still recording this, right? So this is Nora's personal opinion and not my organization's official opinion. I think if you gave the Republicans something that looked and felt like an HSA, you could get a lot in return. And I understand there's philosophical objections to that on the other side of the aisle, and those are legit, and I get it. But in politics, we call it a grand bargain, where each side gives up something really substantive. I think you could get a lot of Republicans to sort of move towards a centrist approach, a year extension on subsidies, 2 years extension on subsidies, in return for something that the Republicans can go home and tell their voters, you know, Heritage Foundation, oh, that's a terrible example. Okay, think tank ABC XYZ has identified for 10 years, we've written papers about HSAs, and now we have them in some, you know, awkward, limited sense. And maybe it's an HSA that covers the deductibles on the exchanges that people can't get to. Like there's different ways you could arrange that. I just think if the Republicans do really, really well with MAGA candidates in the primaries, traditionally, this is a midterm where the president loses and maybe loses either the House or the Senate. Probably won't be the Senate because of the maps, could easily lose the House. And then you have a stalemate. And then you also have an opportunity, though, for some sort of a grand bargain where each side gives up something big and gets something big for their constituencies. I think that's a possible path. I think, though, that the likely path is everybody just continues to be a weenie.
Is it a bad time to tell you that the Senate vetoed the ACA subsidies?
Well, they were always going to lose that vote. I mean, yes, I knew that was coming because you could count the votes. They were always going to lose that vote. I think there are people kicking themselves, although I know there were reasons for it, and Lydia may know better than I do, for putting the 5-year sunset on the subsidies. I mean, it was COVID, we were in a rush, everything was on fire, but there was a sunset date, and that gave the Republicans a really powerful weapon, which is to sit and do nothing. Yeah, I agree.
These are the mistakes that have been made along the way that are going to cause the Democrats to have a big political problem, even in the midterms. I hate to say that, but that's.
Well, look, nobody's covering themselves in glory here. Let's be really honest. Neither political party has terribly high ratings. People I find this to be so interesting as a poli-sci person. People tend to really like and think highly of their elected official from their district. And then the farther you get out, the lower the ratings go. So I think the last couple of Congresses have shattered records for sucking because they've just been terrible. I don't know how else to describe it. But then people feel strong individual loyalty to their individual congressperson and they send them back to DC and the pattern just repeats itself.
To my perception, the same is true of their lawyers and their doctors.
Joe said it, not me. I know we're coming up on time. I wanted to see, was there anything in the chat or anything else anyone wants pontification about while I've got the mic? I have opinions. strongly held religious beliefs about these things. Here's the other thing that's possible, because I'm an optimist. So let me say this. The flip side of my grump that anecdotes are not data is that anecdotes change policy sometimes better than data does. So if you think about EMTALA and the roots of EMTALA, what were the roots of EMTALA? People were being dumped on the street outside emergency room doors, and the hospitals were not taking them in. And so Congress had to act. So it's always possible that we have some really tragic thing happen, like in the AI discussion this morning, the chatbot in Florida that encouraged the young man to take his own life prompted a spate of regulation and litigation. And I believe they've already lost on First Amendment grounds. Isn't that correct? So it's moving forward. Yeah. And then the Ryan Height, in our own backyard as a policy team. So the other possible outcome as we spin the wheel of fortune for what might happen down the road is that we have an incident, and the incident is enough to give political cover to both parties to walk to the middle and craft something that's a solution. And I will tell you, having worked on major pieces of legislation, state and federal, for 30 years, that's actually more likely than the idea that they're going to come to their senses.
Yeah, thank you so much. And if you're interested in hearing more, Nora did a webinar with us back in July. I think it's called Pixels and Payments, Telehealth's New Reality under the One Big Beautiful Bill Act. The recording's available on CTeL's website through your member portal. If you haven't watched it already, I highly recommend. But yeah, thank you so much. We're going to continue this discussion, but now turn towards private payers and these issues with Medicare Advantage and other private payers. And so we have two speakers joining us for this one. We have Penny Kite, who is with Ballad Health, as well as Clarence Williams with Luminous Health. Thank you both so much. I'll turn it over to you.